The patient should be relaxed. Avoid cross-leg position. As a doctor, you need to be relaxed as well. Maintain eye contact. It is difficult for a doctor to examine a patient if he or she is leaning backwards, as a doctor's tendency is to lean forward. Have the patient lean forward so it is easier to adjust the position accordingly to the body part you want to assess. Keep the space between the patient and the physician open as much as possible, taking out unnecessary obstruction. Create an imaginary square. The doctor and the patient should sit at the opposite corners. Head mirrors reflect the light to the areas that are to be examined. They have adjustable head straps that ensure a snug and comfortable fit. The mirror is positioned over the left eye and the light is focused on the area to be examined. Both eyes are open during the examination, the left eye peering through the hole of the mirror. The otoscope is held firmly at the base or the body with one hand while the other hand pulls the pinna. Gently brace the hand with the otoscope to the patient's face. This allows the hand to follow on due movements of the patient. Ask the patient to hold her nose and make the Valsalva maneuver. This is done as an alternative for the pneumatic otoscope. A vibrating tuning fork is placed in the midline of the forehead, chin, or vertex, equidistant from the patient's ears. The patient is asked if the sound is louder on one side or is heard midline. If the sound is heard equally in the midline, it is reported as Weber negative. If sound is heard louder on one side or lateralizes, then it is reported as Weber left or Weber right, depending on which side the sound is heard louder. A vibrating tuning fork is placed on the mastoid process and then by the ear canal. The patient determines whether the sound is louder when the tuning fork is by the canal or on the mastoid process. If the sound is louder when the tuning fork is by the canal than on the mastoid bone, it is reported as Rene positive. If the sound is louder when the tuning fork is on the mastoid bone than it is by the canal, then it is reported as Rene negative. Using your head mirror and the light source, observe the external appearance of the nose, as it may give an indication of a generalized skin disorder. Note for any deformity in the nasal skeleton. This may point to a previous nasal injury as a cause for nasal obstruction. With the use of the tip of the nasal speculum, examine the nasal vestibule, noting for any swelling or crusting. One can also examine the nasal vestibule even without a speculum by simply elevating the tip of the nose. Perform anterior rhinoscopy. The speculum should be directed laterally to avoid touching the sensitive septum. Touching the septum may injure the Kieselbach's plexus, resulting in epistaxis. Identify the inferior turbinate. Identify the middle turbinate. Note its mucosa. Note for any discharge from the middle meatus. Identify the septum. Note for any deviation or any contact with any of the turbinates. After the examination, close the speculum a little before pulling it out. Perform palpation and percussion over the frontal and maxillary sinuses. Sit the patient upright. Adjust the head mirror directing the light to the oral cavity. Start with the examination of the lips. Observe the color and moisture. Note for any lumps, ulcers, cracking, or scaliness. Ask the patient to open the mouth and with the tongue depressor, examine the oral mucosa. Observe the color, check for ulcers, white patches, and nodules. Observe the color of the gums. Inspect the gingival margins for swelling and ulceration. Check the teeth. Check for missing, discoloration, abnormally positioned teeth. Inspect the color of the arch of the hard palate. Ask the patient to put out his or her tongue. Observe for symmetry. Note for the color and texture of the dorsum of the tongue. Inspect the sides, undersurface of the tongue, and floor of the mouth. With the patient's mouth open but the tongue not protruded, ask the patient to say "ah." With this maneuver, you may see the pharynx. Inspect the hard palate, soft palate, uvula, anterior and posterior tonsillar pillars, tonsils, and pharynx. Note their color, symmetry. Look for exudates, swelling, ulcerations, or tonsillar enlargement. With the patient's mouth open wide, the tongue is depressed with a metal or wooden tongue depressor. The number 0 nasopharyngeal mirror is warmed so that the patient's breath will not fog the mirror. After the examiner checks the temperature of the mirror is slowly placed inside the mouth and positioned at the posterior pharynx. To prevent gag reflex, be careful not to touch the posterior third of the tongue with the mirror. The patient is then asked to breathe through the nose, thus depressing the soft palate and enabling the examiner to visualize the nasopharynx. Rotating the mirror allows the examination of the whole nasopharyngeal structure. Check the posterior choanae, septum, superior and middle turbinates, and torus tubarius and the eustachian tube orifices. Check for any tumors or discharges. With a 4x4 gauze pad between the thumb and the index finger of the thumb and middle finger, the anterior portion of the patient's tongue is gently grasped and pulled out. With a light focus on the patient's oropharynx, gently insert the mirror angled downward until you can visualize the laryngeal and hypopharyngeal structures. To evaluate the movement of the vocal folds, ask the patient to say "ee." To evaluate the anterior aspect of the vocal folds, ask the patient to say "e" in a higher pitch. Visualize also the vallecula, base of the tongue, piriform sinuses, and posterior pharyngeal wall. Inspect the structures for symmetry and for any mucosal abnormalities.